Good afternoon, dear chair and dear audience. First of all, I would also like to thank the invitation. It's an honor to speak here. My name is Csenge Szigetváry. I'm currently working at Semmelweis University Department of Anesthesiology and Intensive Therapy. And I'm also a PhD student of Zsolt Molnár and Zoltán Ruszkai. And one of the topics related to our research was about intraoperative individualized ventilation and postoperative pulmonary complications. So in this presentation, I would like to talk about a few topics. What are PPCs? Why are they important? How can we potentially influence them? What are some intraoperative individualized ventilation methods? And what are its effects on the incidence of PPCs? So PPCs are, due to an established consensus, are postoperative atelectasis, pneumonia, RDS, pulmonary aspiration. And their incidence varies depending on the type of surgery, the characteristics of the population we examine. For example, in abdominal surgery, they range from approximately 3 to 30%. And they are in connection with increased morbidity and mortality, and also may lead to economic costs and strain on the healthcare system, especially pronounced in the most vulnerable populations like the elderly, the ones with previous lung diseases, etc. So their predisposing causes and management are very multifactorial. Some factors cannot really be modified, such as the age of the patient, their pre-existing medical conditions. However, there are several perioperative management strategies that are available to reduce the risk for PPCs. And among the preventive interventions, this study identified strong evidence supporting lung protective ventilation, for example, as well as usage of epidural analgesia and also respiratory physiotherapy. In this presentation, I will focus on the ventilation here. So, lung protective ventilation strategies, they were extensively studied before with ARDS and later applied to patients with healthy lungs as well. The recommended ventilator settings aim not only to avoid alveolar overdistension, but also to prevent the tidal collapse and reopening of the lung, which can trigger the release of inflammatory mediators and thus result in ventilator-induced lung injury. And one key element of this approach is the use of PEEP, which helps to prevent this atellect trauma. But what is the optimal level of PEEP that is high enough to prevent atelectasis, but yet low enough to avoid inappropriate overdistension? And the answer is likely varies between patients, and there may not be a universal one-size-fits-all setting. So this is why PEEP titrations are used in order to find this optimized PEEP. These strategies aims to identify the optimal PEEP for that individual patient by assessing the best compliance, the lowest driving pressure, targeting an optimal transpulmonary pressure, a low ultrasound score, or optimizing ventilation with the help of the electrical impedance tomograph. So, what do we know so far? Well, several randomized control trials over the past decade have compared individualized PEEP titration settings with conventional settings. However, the results regarding the PPCs remain inconclusive. And to address this uncertainty in the previously existing literature, as part of the PhD studies, we conducted a meta-analysis, including 30 studies comparing patients receiving individualized versus conventional settings during abdominal surgery. And our primary outcome was the incidence of PPCs. And based on our study, it was about 30% less likely to get a postoperative pulmonary complication if individualized methods was used. What do other reviews say? Well, they reported findings consistent with our results. For example, Sorilla and its team investigated the same population, patients undergoing abdominal surgery, and receiving with the very same or very close result with a risk ratio of 0.69. And there are two other reviews which I want to mention. They focused on thoracic surgery with one lung ventilation, both finding a prominently reduced risk of postoperative pulmonary complications, nearly 50% less likeliness. We were also interested in what the individually titrated value will be. And it turned out to be higher than the predefined values, which ranged from 5 to 7 centimeters of water on average. And their settings were not only higher, but nearly double, as the mean difference and the overall mean difference showed us more than 6 centimeters of water higher peak value when individually titration was used. And an interesting thing regarding the subgroup analysis, we observed a more prominent elevation in the group where there were patients undergoing laparoscopic surgery and when they were obese. I want to mention that in a previous trial, the PROBREEZE trial, higher versus lower PEEF strategies were already compared, but there were no significant differences there regarding postoperative pulmonary complications. Similarly, in our subgroup of obese patients undergoing laparoscopic surgery, the intervention appeared to have no effect on the incidence of postoperative pulmonary complications. However, as this subgroup analysis was based on only 2 studies, this evidence is insufficient to draw a firm conclusion. About oxygenation, in the individualized the titration group, oxygenation was on average 65 millimeters of mercury higher at the end of surgery. And this was even more pronounced again in the subgroup of obese patients undergoing laparoscopic surgery with more than 60 millimeters of mercury. And these findings are consistent with the PROBREEZE trial, which I mentioned before, because their higher PEEP was also associated with improved oxygenation. We also observed similar trends regarding the reduction in driving pressure. Overall, the study group had a mean driving pressure reduction of 2.75 centimeters of water at lower compared to the controls, with an even greater reduction again seen in the obese patient, with more than 7. We also observed an improvement in the respiratory compliance, showing the same subgroup tendencies like I've mentioned before. As a conclusion, based on our findings, individually titrated PEEP significantly lowered the PPCs in this study. It improved early postoperative oxygenation and may also enhance lung mechanics compared to conventional settings. Of course, further studies and further investigation should be needed on a more homogeneous population with more standardized titration methods. And regarding the future, particular attention should be given to vulnerable populations such as the obese patients and patients undergoing thoracic surgery, receiving one lung ventilation, and to find out who may benefit most from these ventilation strategies. I just want to mention some other settings, just a few words in the intraoperative period about recruitment maneuvers on PPCs, which is another actively researched area, but so far no firm conclusion can be drawn. For example, there's this study on the left reported a relative risk of 0.67 for PPCs, suggesting some potential benefits in reducing PPCs in obese patients, PPCs. But regarding some other RCTs, especially even in the promising population, like patients with obesity, there were no significant difference in PPCs with or without recruitment maneuver. And if individualization, while it's not a ventilation strategy, I just want to mention goal-directed fluid therapy, which also another field of research, but with some moderate quality of evidence so far, with 25 relative risk reduction regarding PPCs, but all these still suggest only weak supports in PPCs, so further investigation is needed in this area. As a summary, well, despite the number of high-quality trials that are already out there, for me, this field still feels somewhat under-investigated. This is largely due to the complexity of mechanical ventilation and perioperative care, which manifests as considerable heterogeneity among studies. So this is what came to my mind. If knowledge would be represented by a circle and experience by the radius, the more we know is just the more contact we have with the things we don't know. And I feel like we are so close, yet so far, to find the answer to what is, how should someone individualizedly be ventilated in order to improve outcomes. Thank you very much.